Once again, welcome to this part of our big day out, the Orthosports Orthopaedic and Sports Medicine update. I'm Dr John Best, a sports physician in the Randwick rooms, and we have Dr John Negrine, foot and ankle surgeon, who very much has had an international flavour to his training, including a fellowship in Dallas, Texas. We'll come back to that possibly a bit later with our second case, but we're going to have a true conversation about two clinical problems. And John, we're going to start with the Achilles. What's the background of the story of the Achilles heel, first of all?
The Achilles goes back a long way into Greek mythology. So the story of Achilles comes from a poem by Homer called the Iliad. And Achilles was dipped into the river Styx by his mother Thetis, and the heel was held, and she dipped him in to protect him from evil and from danger. Unfortunately, he was then in a battle between the Greeks and the Trojans, and he was shot, would you believe, in the heel, by Paris, and he succumbed. And so from then on, the Achilles heel has been synonymous with a weak part of the body. There you are.
Do you remember in your early years, either as a medical student or junior doctor, where you just misdiagnosed these or were surprised by them?
Well, interesting you should say that, because in our country, in the US and in the UK, 25% of them are missed by the first doctor that sees them. And often the scenario is a Sunday afternoon, it's a middle-aged person, they've been playing squash or tennis, they feel a pop, an x-ray is taken, they don't examine the patient, and the diagnosis is missed. And unfortunately, I even saw a patient last week who had a missed Achilles rupture 5 weeks out.
So 1 in 4 misdiagnosis by the first clinician. That's interesting. Look, you've got a case for us that you want to present, and we'll talk about the management. Tell us about this 58-year-old.
Okay, so this is a 58-year-old sports physician, not too far from where we are at the moment, and he's playing a ballistic sport such as badminton, such as squash, such as tennis, and he feels as though somebody's whacked him in the back of the leg. So he stumbles away, he's unable to walk. He is examined, and he's found to have a palpable defect posteriorly. At a positive Thompson test, squeeze the calf, the foot doesn't move. I always do take an x-ray because there's occasionally a piece of bone that's pulled off, and he's pulled off his Achilles insertion, which makes it much harder technically. Now, this 58-year-old sports physician is very, very active, and he won't put up with limping for the rest of his life, and he wants to get back to sport. And so we do have to treat him, and we can treat him with or without surgery. Now, the pros and cons is actually quite controversial. Traditionally in this country we have managed them surgically. Traditionally in Canada and in the USA they've managed them non-surgically. What are the pros and cons? If, in my opinion, the sports physician is a healthy chap, he doesn't smoke 100 cigarettes a day, he doesn't have diabetes, he doesn't have significant comorbidities, he will get a faster, stronger result with a lower incidence of re-rupture with surgical treatment.
Okay.
If, however, he has a comorbidity, let's say he suffers rheumatoid arthritis, he's on immune suppressive drugs, he's a surgical risk, then non-surgical treatment is safer. The problem with non-surgical treatment is you need a very compliant patient. If you happen to have a look at the Achilles here and picture it rupturing, the heel has to be held in full plantar flexion for at least 4 weeks. It's not sufficient to put a boot on the patient and say, go away, take the boot off to have a shower, take the boot off to go to bed. They've got to keep it on day and night to allow it to heal. The non-surgical treatment takes at least 8 weeks, and the incidence of re-rupture, we believe, is higher. There is no way on earth in a competitive athlete that you would manage them non-surgically. Fortunately, however, Achilles tendon ruptures are very rare in competitive athletes.
Just picking up a couple of clinical signs. So in the rooms, what's their weight-bearing plantar flexion like, their calf and toe raises?
Well, interestingly, most of them can walk.
Yes.
Most of them have plantar flexion but can't heel raise.
Okay.
And the reason why they still have plantar flexion is, if you can picture the anatomy, they still have function in tibialis posterior, in flexor hallucis longus and flexor digitorum longus, all of which are plantar flexors. But it's a sort of diagnosis, like so many things in medicine, you see what you look for and recognise what you know. And in general, most of us can pick it over the phone.
We might just talk a bit about imaging. It's very much a clinical diagnosis. An old surgeon teacher of mine said, listen to your patient, they're telling you the diagnosis, which is very true here. You and I have seen patients who've had ultrasounds and it says partial tears. And what's the role of imaging in this setting, John?
I get a plain x-ray, again, to diagnose the avulsed bony fragment. Ultrasound is not helpful because it can lead to a mistaken diagnosis. If a few fibres are still intact On ultrasound, they call it a partial rupture. I've then seen patients go off and have physiotherapy for 6 or 8 weeks when in fact it was a complete rupture. So in the situation where the patient comes in with an x-ray, I don't order an ultrasound, it's a clinical diagnosis. Sometimes you see a patient who's very difficult to examine, they might be rather obese, the history may be a little bit difficult to elicit from them, they may have had 2 or 3 episodes, in that case MRI can be helpful. But in general, I would say 98% of the time it's a clinical diagnosis.
And return to sport and rehab in terms of time frames?
Well, that's very interesting.
Controlling expectations.
That's very interesting. In professional athletes, probably 75% will get back and 25% won't. And there's a very interesting study which was done some time ago where they got Achilles tendon rupture patients and managed them surgically. And at surgery they implanted 2 metal markers on either side of the rupture. And they treated the patients in plaster and some of them with active movement and some of them traditional kinds of treatment. And over time they took serial x-rays to see whether or not the Achilles lengthened. And they found that irrespective of how the patient was treated post-operatively, the Achilles lengthens in a proportion of patients. And if the Achilles lengthens, that translates to decreased push-off strength, which can be one of the reasons why a high-performance athlete doesn't get back to their previous level of activity. But in terms of what you were mentioning before, I usually say walk, cycle and swim 6 to 8 weeks, running usually 6 to 9 months, although a couple of rugby league players, we've managed to get them back inside 6 months with extensive physiotherapy.
I must say, as a physician, when I've seen patients who've had previous Achilles surgery, even a decade or 2 ago, they're very happy with the results. They say it's never been a problem.
Okay.
It's sort of like putting money in the bank, I think, in the days where you didn't have to worry too much about banks. Thanks, John. We're going to move on to our second case, part 2 with Dr John Negrine, and John would agree with me, we do appreciate in particular Duroncher's organisation of our big day out once again and our staff. So good job, Duron, you're improving all the time. John's nickname in the office is Foot, but we're going to move to the toe and we're going to look at the big toe. So Johnny, a patient comes to see you middle-aged with a sore big toe. What are the non-mechanical things you'd be thinking of before we talk about some of the mechanical causes?
Well, one of the commonest things that happens in the big toe is gout. And the typical history is the patient comes in with no history of injury and the big toe is red hot, swollen and hurts like the devil. Now many years ago they observed that gout was more common in the big toe, but only recently they found out why. It's because the big toe is one of the coldest joints in the body and uric acid precipitates out in the cold. The things that often precipitate an attack of gout would be purines in the diet, tomatoes, red wine, blue cheese.
All the things we like.
All the things we like.
Yes.
Dehydration, so the patients come off an airline flight and they develop an attack of gout. And actually fasting at the time of surgery can often precipitate an attack of gout.
Okay, that's interesting.
And when you see it, it's red, hot, swollen, the joint is painful in all planes to move. What is the differential of that? Blood-borne infection is very rare. I mean, if the patient's an IV drug abuser, that's easy. But in general, even in patients with diabetes, blood-borne infection is rare. How do you sort out the gout from the other diagnoses? Under sterile conditions, you put a needle in the joint, you send the fluid off for a cell count, for a gram stain, and for a search under polarized light looking for crystals. And if they see the crystals under polarized light, then you've got the diagnosis.
Johnny, other causes of great toe pain, even other toes, just to
well, you could get
reflect on that.
well, occasionally you get reactive arthritis or psoriatic arthritis.
Yeah.
And the funny part with psoriatic arthritis is that a lot of people who get it don't even have psoriasis. Do you tend to see reactive arthritis in your practice?
Not a great deal. You certainly don't see it from common infections, but I have been away with teams and you do get athletes who get sexually transmitted diseases, and we should just keep all these things in the back of our mind. Now, you've got a patient for us
I have.
with a stiff sore big toe.
Okay, so this gentleman, I actually saw him today. He's a 64-year-old retired airline captain and he is extremely active. He told me he ran 10 kilometres yesterday and tries to run 30 kilometres a week on roads. He's a skier, he's a mountain climber, and he's got a painful, stiff, big toe. Now, when you examine him, he's got a barely 30-degree arc of motion. He has a large dorsal osteophyte, and interestingly, his pain is mostly at the end of dorsiflexion. The mid-range is not as painful. Mediolateral movement, not as painful. You take an x-ray, and he's got precious little cartilage left. So he's really at, what we would call a grade 3. Now, what can you do in this chap? He obviously doesn't want a fusion because he's been told by his podiatrist that a fusion's very bad and you can't do anything with a fusion, which is actually not true, because Leighton Hewitt played his last 2 years of tennis at Wimbledon and the US Open with a fusion. But anyhow, how do we retain movement in this chap? Mentioned to condemn, this is a device called a Cartiva, which is a piece of polyvinyl acetate. If you remember those little super balls that people used to bounce on the ground, a Cartiva came out some years ago with much fanfare as being the solution to the active patient with advanced arthritis, in the sense that it was going to retain movement and it was going to get rid of pain. And there was a level 1 study. There was a randomized control trial of 150 patients, randomized to fusion or Cartiva, and in this trial they found non-inferiority. Now, non-inferiority is a very interesting thing, because in order to prove superiority, you need a higher power statistically. But in order to prove non-inferiority and get this thing approved by the FDA, they needed 150 patients. And so this was brought out and everybody was very happy, and one of the foot surgeons in town had Channel 7 in his operating theatre and it all sounded great. Unfortunately, the results have not been great. And so in our contest captain, who's got the mid-range, which is non-tender, I'm going to perform a chelectomy, which is to remove 1/3 of the dorsum of the joint and the metatarsal head to keep his movement, and should that fail, then he gets a fusion. I've advised him as well that at 64 with an arthritic big toe and early degenerative change in his knee, perhaps running on roads is not the best exercise for him.
Well, what about range of motion that's required for comfort walking or brisk walking? How much do you actually need?
Well, I think 30 or 40 degrees is fine for walking.
Yeah.
But I mean, if people want to run, and as you know, people are now running into their 60s and 70s and 80s, what do you see from that point of view?
Look, my hot tip for the audience is, particularly if you're coastal, is soft sand running. It's interesting because that's a toe poking biomechanic. It's not a heel strike, pronate and push off. It can be done with or without shoes. The benefits health-wise are still there, but then obviously looking at less impact through the bike, through the rowing machine, etc. If people are looking at fusion surgery, when's a good age to do that, and what's the recovery like?
Well, for men, the age is really not as important as it is for ladies. A fusion in a man having a fusion will generally be happy. They have a lot of pain. You fix it, they can walk. It's a day surgery. It's 6 weeks recovery. The fusion is done using a plate and screws, and it works, 80-90% of the time. Women, if they're still wearing high-heeled shoes, if they're still doing yoga, doing positions such as the downward dog, they do not like a fusion.
Yeah.
I had a lady some years ago, very high heels, very bad pain. And I fused her and she came back and I said, "How do you feel?" She said, "I've got no pain, but I'm miserable." Why are you miserable? Because I can't wear my high-heeled shoes. Would you have had the surgery again? No, I would not have had the surgery again. So it's a very salutary lesson that biological age, and in fact, as you know, ladies now, wearing high heels into 70s and 80s.
Well, final comment, as a surgeon, your view of orthotics for a setting like this?
All right, in a runner, if you have an orthotic which is lengthened beneath the first MTP joint with a carbon fibre extension to decrease that extension, it can be helpful. Unfortunately, all too often we see arch supports for this condition, which really are not all that helpful. The other issue is that sometimes when people have an arthritic big toe, the arthritis is not only in the joint, but also in the sesamoid metatarsal joint, which can also benefit from cushioning. But orthotics are worth a try.
Thank you. Well, 2 good cases from the foot from Dr. John Negrine, and I hope you found it helpful. Thank you.